Hi, I'm Lindsay Bennett, Healthcare Finance Executive, and in today's video, I'm going to explain healthcare finance the way that healthcare CFOs actually use it. I am going to break down this master's level topic in plain language, no finance degree required. And you'll want to stick around until the end because I'm going to give you access to these slides for free, as well as some formula sheets and other things that will help you out.
Before we start the timer, here's what I'm going to cover in under 25 minutes. We're going to talk about why healthcare finance is unique. We're going to go over the different healthcare payers, charges, reimbursement, and alternative payment models. I'll cover the revenue cycle, the different financial statements and financial ratios. We'll talk about budgeting and forecasting and how CFOs evaluate capital expenditures. We'll talk about staffing models and productivity, variance analysis, and key performance indicators, cost structures used in healthcare finance, and how to calculate break even, as well as the future of healthcare finance. You're probably here because you've realized that healthcare finance is complicated. Well, why is that? It's because of who pays for it. In the United States, we have a mix of third parties and consumers, and revenue can be paid weeks or months later after the service is performed, or never at all. Costs are largely fixed and they are clinically driven by the patient's condition, and payment doesn't always correlate with customer satisfaction. Also, you have regulations that determine the margins that healthcare providers can make, so payment rates are not market driven. Welcome to Section 1, which is reimbursement, payers, and payer methodologies. Who pays for healthcare in the United States? There are three main categories. The first is third-party government payers. These include Medicare, which is a federal program for people ages 65 and up, the disabled, and people with end-stage renal disease. You also have Medicaid, which is a joint federal and state program for low-income individuals and families with coverage that varies by state and typically includes children, low-income seniors in long-term care or nursing facilities, etc. You also have military and veteran health programs such as the VA and TRICARE, and there are government-funded safety net special programs such as Ryan White and Tribal Health. Then you have third-party private payers, which includes commercial insurance, which are the names that you probably recognize, like Blue Cross Blue Shield, United Health Group, Aetna, Cigna, etc. You have individual market and ACA plans. Then there are liability and indemnity plans, which are things such as auto accident insurance and workers' compensation. There are Medicare Advantage plans, which are interesting because those are funded by the federal government, but they contract with third-party private payers to administer Medicare Advantage plans. And similarly, Medicaid managed care plans are administered by private payers on behalf of the government. Then you have individuals who pay for healthcare. This is patient responsibility such as copays, deductibles, and coinsurance, or they could be paying for care because they are uninsured self-pay patients. And this could be the patient themselves or it could be their guardian. Reimbursement. Some key terms that you need to know are gross charges. That is the published price list for a provider, but that's not actually what providers get paid. Typically, providers get paid an allowable, also known as a fee schedule amount, which is determined by the government in the case of Medicare and Medicaid, or it is determined in the contract between the provider and the insurance company, which gives them the fee schedule amount. That's what the provider actually gets paid. And the difference between those two is called the contractual allowance. Payer mix is an important concept. It refers to the percentage of the total volume or revenue that each payer has. Payer mix is important because it is one of the strongest drivers of financial performance, and slight shifts in payer mix can actually erode margin, even if the volume doesn't change. Different provider types are paid using different payment methodologies, and I actually do a separate YouTube video series on exactly how to calculate the reimbursement for each of these provider types. Hospital inpatient stays are paid using a prospective payment system based on diagnosis-related groups, or DRGs. That means that the hospital gets a fixed payment for each admission, regardless of whether the patient stays for 7 days or for 10 days. That's why hospitals have to manage their length of stay, because every extra day that the patient is there, they're incurring costs in the form of nursing care and supplies. Physicians are paid by CPT code based on a fee schedule that's set by the Resource-Based Relative Value Scale, or RBRVS. Hospices are paid a daily rate based on the level of care, and skilled nursing facilities are paid by PDPM, which are daily payments determined by base rates for different components with various weights applied to them. Hospital outpatient services are paid using APCs, or ambulatory payment classifications, which are packagings of a primary service along with related items. Home health agencies are paid using the patient-driven groupings model, or PDGM, which pays for 30 and 60-day episodes of care. Ambulatory surgery centers are paid using CPTs and APCs, and clinical laboratories are paid by CPT and HCPCS codes under the clinical laboratory fee schedule. You also have alternative payment models because right now the industry is shifting away from fee-for-service and from paying for volume to paying for value. Different types of alternative payment models include primary care models, such as accountable care organizations, whether they are participating in shared savings models or if they are taking on downside risk. You have primary care capitation, which is per member per month. Then you have direct primary care and advanced primary care models. There are also condition-specific models, such as bundled payments for things like a total knee replacement, and disease-specific models for things like kidney disease. Then you have population models, which are usually capitated or partially capitated models, where the provider organization is paid to assume global full risk across the spectrum of healthcare, including various things like hospitalization and durable medical equipment, etc. Now let's look at the revenue cycle, and I have an entire playlist devoted to this topic if you want to know more about it. Revenue cycle is how the money flows, and it is critical to cash flow and being able to meet payroll obligations, pay the rent, etc. It starts in the upper left-hand corner here with patient registration, which is when the patient first contacts a provider for services, and it ends when the patient's balance is zero, meaning that it's either been paid or it's been written off. So we start with patient registration and scheduling, which is where we collect demographic and insurance data, and if that's not accurate, we might not get paid. Then we move into checking insurance eligibility, verifying the patient's benefits and that we have coverage for the services we plan to provide, and seeking any pre-authorizations that are required by the payer. That is what is known as front-end revenue cycle. Then we move to mid-cycle, which is charge capture and coding. The patient comes in at the time of service, and there are various diagnoses and services that get documented in the EMR, and those services and diagnoses are coded. Then we move into the back end of revenue cycle, starting with claim submission, which is where claims are generated. They are scrubbed for common errors. They're submitted through a clearinghouse to the payer, and any errors or rejections are corrected. Hopefully, we then receive payment, and we have to post not only payments, but also adjustments and denials. That's the contractual adjustments we talked about earlier, plus any denials from the insurer. And then there's also the coordination of benefits that takes place, which is where we issue another claim to any secondary or tertiary payers. Then we move on to collections. So if after posting payments and adjustments, there's still a balance on the patient's account, then we might do a claim status inquiry. We may work denials, or we may send appeals to the payer. Or we may decide to write off the remaining balance, either because it was denied, or in the case of patient balances, maybe it goes to bad debt. Section 3, Healthcare Financial Planning and Analysis. There are three main types of healthcare financial statements, which are the balance sheet, the income statement, and the statement of cash flows. The balance sheet is a point in time. It will always have a date at the top of it. It lists the assets, liabilities, and equity that the company has at a point in time. It's a snapshot of what the organization owns, owes, and retains. Then you have the income statement, which is the revenue minus expenses equals the profit or loss for a period of time. So this could be for a month, it could be for a whole year, it could be year to date. But the income statement measures the operating performance over a period of time by matching revenues earned and expenses incurred in that period. That's an important concept called accrual accounting, which means that we know the payers may pay us weeks or months later, but we are matching the activity in terms of revenue and expenses within that month. Then we move on to the statement of cash flows, which is the actual cash in and out, where it came from and where it went. The statement of cash flows tracks how cash is used in different categories: operating, investing, and financing activities, and it is highly impacted by revenue cycle. Financial ratios. These are indicators of an organization's financial health, or in many cases, financial distress. They are used by boards, by auditors, and creditors. And there are 4 different types of them. There are liquidity, efficiency, profitability, and leverage ratios. Some typical liquidity ratios include the current ratio, which takes the current assets on the balance sheet divided by the current liabilities on the balance sheet. And you want that number to be higher because what it's showing you is the number of dollars of current assets that are available to cover your current liabilities. The debt service coverage ratio is one that's very important to healthcare CFOs because it describes the ability of the organization to cover its debt at different levels of income. If the organization is borrowing, this is something the bank always looks at. Also, the auditors. Under efficiency ratios, some common ones are AR turnover, which is the net revenue from the income statement divided by the average AR balance from the balance sheets. Then you have operating efficiency ratio, which measures the amount of spending to generate revenue. That's the operating expenses from the income statement divided by the operating revenue line from the income statement. Profitability ratios measure the ability to generate profit from revenue, or how effectively income is being converted into a surplus after covering costs. The big ones are net margin and operating margin. And then we have leverage ratios, which determine how much capital comes from debt and how much the organization is using debt. A common one is the debt ratio, which is the total debt from the balance sheet divided by the total assets from the balance sheet. Budgets and forecasts. The purpose of budgeting is to translate the strategic plan into a financial and numerical roadmap to get you from where you are now to where you hope to be in the strategic plan. It's what aligns strategy with operations, and it's an allocation of resources. The budget creates a structure for financial accountability, and it enables performance management. However, budgets have some limitations, and that is that healthcare is very dynamic. It's always changing. So the underlying assumptions in the budget may be obsolete by the time the budget year rolls around. And this is because it can take months to put together a budget for a large health system. The budget is also subject to behavioral influence, such as sandbagging and gaming by the various managers. There are 2 types of budgets, the capital budget and the operating budget. The capital budget is the plan for major long-term multi-year investments in things like buildings and renovation or expensive technology and equipment. The operating budget is a plan or projection of the day-to-day revenue and expenses. So how do these 2 types of budgets interact? Well, in the capital budget, when you make a large purchase, it is depreciated or amortized, and that depreciation and amortization expense ends up in the operating budget. Also, if you are investing in equipment and technology, you are hopefully improving capacity and productivity, and that would also be reflected in the operating budget in volumes, revenues, labor expense, etc. Then if you're buying software, for example, you might have maintenance contracts, and those would be in the operating budget. And if you're financing any of the capital purchases, the interest expense ends up in the operating budget. Evaluating capital expenditures. If you're a healthcare CFO, you have a finite amount of resources to invest, but you have all these different opportunities you have to choose between. Some examples are artificial intelligence investments, EMR upgrades, an OR expansion, remodeling a floor in the hospital, buying new updated imaging equipment, or investing in revenue cycle automation tools. So how do CFOs decide between all these different projects? Well, there are qualitative and strategic considerations. Some of the financial metrics that they use to compare different capital expenditures are ROI, which is return on investment, and that tells you how profitable an investment is relative to other possible investments. And you calculate that by taking the incremental benefits or cash flows minus any incremental cost, and you take that number and divide it by the capital outlay, and it gives you a percentage. Another one is net present value, or NPV. That is the current value of all of the future net cash flows. NPV is calculated by taking the present value of the projected future net cash flows minus the capital outlay. Another one is the internal rate of return, or IRR. That is the discount rate that makes net present value equal to 0. So what IRR solves for is the present value of cash inflows minus the investment so that it equals zero. Basically, it's just giving you a rate of return for all the different projects you're comparing so that you can look at that side by side. Payback period is probably the most simple to understand. It is the time until the cumulative net cash flows equal the initial investment. So you take the capital outlay and you divide it by the annual net projected cash inflows. Budgeting and forecasting, what's the difference between the two? A budget is a fixed financial plan built in advance to guide operations and set expectations, while a forecast is a dynamic update that revises projections based on actual performance and current conditions. Budgets establish accountability while forecasts support decision making as conditions are changing. Now, the methods for creating them are very similar. There are different ways to budget, but the most common for large healthcare organizations is called driver based budgeting. Driver based budgeting builds an operating budget by linking revenue and expense projections to the operational factors that actually drive them, such as patient volume, visits, case mix, staffing ratios, and payer mix, rather than relying on just adding an increase to prior year totals. The budget is created by forecasting key drivers first and then translating those drivers into revenue, labor costs, and supply costs. On the right side of the slide is an actual hospital income statement, and I've redacted the numbers on there, even though this is posted publicly online. Basically, all you're doing is you are using these methods to populate a projected income statement, and that's your operating budget or your forecast. Staffing models are widely used in healthcare because labor is the largest controllable expense, and the level of staff directly impacts quality, patient safety, patient access, and profitability. Also, you have statutory minimum staffing requirements in some areas, and under prospective and value-based payment models, staffing costs can quickly erode profit margin, which is why we monitor it so closely. Also, staffing models give us scalability and resilience during volume swings. On the right side of this slide, we have an example of an inpatient adult psych unit in a hospital. And on the left-hand side of that grid, you can see the census levels and the number of RNs and mental health techs that are needed for that level of census for each shift. In this example, we have two 12-hour shifts totaling 24 hours a day, but it could be three 8-hour shifts. But what you need to know is that at a census of 12, even though you're only trying to maintain one RN and one mental health tech per shift, that's really 4.62 full-time equivalents of each of those. And that's because, again, you're staffing 7 days a week, 24 hours. And also, you have to replace those people when they are non-productive. So when they're out sick or they're on vacation or they get called for jury duty, somebody still has to be on the unit taking care of the patient. So we make an estimate of the non-productive time, in this example, 10%, and we add that in. So all of those components together get us to 4.62 RNs and 4.62 mental health techs needed to maintain that level of staffing. Now, staffing models tie directly into productivity because staffing models tell you the right number and the right mix of staff that you need for an expected level of volume. Meanwhile, productivity compares your actual units of service per unit of time to your target unit of service per unit of time. And when we say target, we usually mean budget. So some examples of productivity measures for physicians are on the left. Those can be things like worked relative value units or WRVUs. Those are common. Also patient panel size, how many patients are assigned to a provider to manage, the average number of visits per day, or in the case of a surgeon, procedures per day. On the hospital and facility side, it could be nursing hours per patient day, or it could be cases per OR hour. When we define productive time, we are normally talking about payroll categories like regular pay and overtime, which is direct bedside time. Non-productive time is often paid, but it includes things like vacation time, sick time, jury duty, and orientation. And in those instances, you have to replace that so that there's no interruption to patient care. So in the bottom right, you can see the productivity percentage calculation, which is the targeted worked hours per unit of service divided by the actual worked hours per unit of service. In this case, we had a target of 8 hours, but we actually worked 10 hours. So we were less productive. We were 80% productive. Variance analysis. This is where we compare the actual results to the budget and we interpret any favorable or unfavorable variances. And the example on the screen, we have a hospital's financials month to date, and you'll notice that the patient days are over budget, which is favorable. The net patient service revenue is also over budget, but we would expect that based on there being a higher volume. Similarly, with salaries and benefits expense, we are over budget, which is normally a negative thing. But since our volume is up, we do expect salaries and benefits to increase somewhat. So what we need to do is figure out what part of that variance is due to volume and what part is due to rates. So for example, we might be paying more than we want to for labor and more than we budgeted on a per unit basis. So we need to isolate the effect of that volume. We do this by calculating the volume variance, which we do by taking the actual volume minus the budgeted volume and taking that result times the budgeted rate. To calculate the rate variance, we take the actual rate minus the budgeted rate, and then we take that result times the actual volume. And so you can see on the bottom half of the screen here that the revenue variance, the $748,784 up above, can be broken out into $292,416 due to higher than planned revenue per patient day, or the rate, and $456,368 of that is due to the additional patient days. Likewise, for the salaries and benefits expense, we can see that we had an unfavorable rate variance that resulted in a $77,059 variance, and that the part of the salaries and benefits expense increase that was due to the additional patient days was $174,961 of the overall $252,000 salaries and benefits variance. Healthcare KPIs. There are a lot more healthcare KPIs, but we'll focus on some of the main ones. Operating margin. This is the percentage of revenue in excess of expenses, also known as profitability. And this is calculated by taking the operating revenue minus the operating expense and taking that amount, which is your profit or loss, divided by the operating revenue. Days cash on hand is very important to CFOs because this is the number of days that the organization can continue to operate using its available cash and liquid investments. And we do that by taking unrestricted cash and easily liquidated investments and dividing them by the average operating expense per day. The net revenue per unit of service is going to depend on what kind of organization it is, whether it is per discharge or per patient day or per visit, etc. But it is the net revenue divided by the total units of service, and it gives you the average payment per service. Similarly, the cost per unit of service is the operating expenses divided by the units of service, which gives you the average expense per service. And then we have the days in accounts receivable, which is one of the main revenue cycle KPIs. And you get that by taking the net accounts receivable with the credit balances added back divided by the average daily revenue. And this gives you the average number of days that it takes to convert a service into cash. Cost structures and break-even analysis. We have different cost structures in healthcare, direct and indirect costs, which are used in service line profitability, cost accounting, such as cost per case and cost per DRG, and for cost improvement initiatives. Direct costs are the ones that can be traced directly to a patient, department, or service. Examples include nurse time on a unit, drugs administered, surgical supplies used in a case. Indirect costs support patient care, but they are not attributable to a specific patient or service. They need to be allocated. Some examples of this are administration, IT, the accounting department, human resources, utilities, and compliance. Then we have variable and fixed costs, which we use in break-even analysis, in cost profit volume analysis, and in capacity planning. Variable costs are those that change as patient volume or activity changes. Some examples are supplies and drugs, implants, and hourly staffing. Fixed costs are incurred regardless of the volume, and some examples of that are salaried staff, rent, maintenance contracts, and insurance expense. The key difference is that direct and indirect expenses involve traceability to a patient or a service, whereas fixed and variable talks about the behavior with volume. Break-even analysis. When we're planning a new medical clinic or a new line of service, we may do a break-even analysis, which is what tells us the minimum amount of volume that we need in order to not have a loss. Or another way of saying that is the point in units where the total revenue equals the total cost, where we break even. And the way that we do that is when we're planning a new service line or clinic, then we create a model financial statement, a pro forma financial statement for that project. Then what we do is we use two formulas. One is the contribution margin per unit, where we take the revenue per unit minus the variable cost per unit. So you would go look at that modeled income statement for your project, pick out the variable costs, and come up with the variable cost per unit. Then to calculate the break-even number of units, you take the total sum of all the fixed costs divided by the contribution margin per unit. Here's an example. Let's say that we are opening a new imaging center and the fixed costs are $120,000 for the equipment lease, for the maintenance, for the insurance. Meanwhile, we're expecting an average reimbursement per scan of $200. And the variable costs per scan are $50, which is the hourly technician, the supplies, and outsourcing the reading of the scan. So our contribution margin is $200 minus $50, which is $150. So to calculate the break-even number of scans, it's $120,000 in fixed costs divided by $150, and that gets you to 800 scans that you need to break even. And finally, the future of healthcare management. What is changing right now? We are moving away from retrospective reporting to real-time predictive financial management. We're getting away from a monthly close accounting process and delayed variance analysis, and we're moving towards continuous forecasting and scenario modeling. CFOs are no longer focused on fee-for-service and optimizing volume and revenue, but instead they are managing risk, utilization, and the total cost of care, and they need to have value-based care fluency. We are moving away from a model in which finance is independent of clinical operations and now where finance is embedded in clinical and operational decisions. And we're shifting away from labor budgeting towards workforce strategy and automation with AI. We are moving away from annual static budgets and moving towards dynamic rolling forecasts. We have covered so much in less than 25 minutes. In the description below, you'll find a link to my free mailing list where you can take the next step and join me to build the technical skills and knowledge that we only just touched on in this video. Subscribers gain access to free tools and templates and training to help you build your healthcare finance career.